kidney, it is called kidney function test. If you are going to do the function test for pancreas, it will be pancreatic function test. If you are going to do the function test for thyroid, it will be thyroid function test. And if you are going to do the function test for liver, that is liver function test or LFT. LFT is liver function test. So today we are going to see what are all the liver function tests and how to assess whether the liver is normal or not. That is the class today. So for that, you should know what are all the major functions of the liver. What are all the major functions of the liver is, it is doing excretion function. It is doing metabolic function. It is doing some synthesis function. It is doing detoxification function. And it is producing a lot of enzymes. All these will be the functions of the liver. So this will be asked as a short notes question. They will ask about the functions of the liver as a short notes question. 5 marks question. So for that, you will have to categorize them under excretion. So it will excrete the bile pigments and bile salts from the body. Bile pigments and bile salts will be excreted through urine and stools. And intermediary metabolism. Some metabolic activities are taking place, like a galactose metabolism, lipid metabolism. Some metabolic activities, they are taking place in the liver, intermediary metabolism. Then synthesis. They are producing certain important substances like the serum protein. This serum protein, mainly albumin, is produced by the liver. And the serum prothrombin, it is a coagulation factor. Serum prothrombin, it's a coagulation factor which is very, very important for coagulation of blood. Suppose you are plucking the teeth from the patient, so you are removing the teeth, so the bleeding should stop. For this, this prothrombin is very, very important. If the prothrombin is not normal, you cannot do teeth extraction. So, synthesis of protein and prothrombin. Then detoxification of ammonia. Ammonia will be excreted from the body as urea. Ammonia and hippuric acid, both will be excreted from the body by detoxification. And they are producing lot of enzymes. So about which, we will see what are all the enzymes that are produced by the liver, like ALT, AST, then acid phosphatase, alkaline phosphatase. So all these are the enzymes that are being produced by the liver. So this will be the main functions of the liver. And this function continues. Metabolic activities I told. What are all the metabolism that is taking place in the liver will be metabolism of the carbohydrate, metabolism of the lipid, metabolism of the proteins, porphyrins and bile acids. So all these metabolic activities, they take place in the liver. And it synthesizes all proteins except immunoglobulin. So it may be asked as a MCQ question. They will put all the proteins and they will put immunoglobulin also and ask you to find out which one is not being produced by the liver. So you will have to mark immunoglobulin is not produced by the liver, but all the other proteins are produced by the liver. Right? Then storage site of iron, vitamins and glycogen. So in carbohydrate metabolism, they would have told this glucose is being stored as glycogen in the body. So the glycogen is stored in the liver and muscles. So glycogen, vitamins and iron also are stored in the liver. And excretion of metabolic end products like bilirubin, ammonia and bile acids, everything will be excreted metabolically from the liver. and detoxification of the xenobiotics. So all these functions are very, very important functions of the liver. So that's why liver is supposed to be a corporation in the body. The corporation office of the body will be the liver. Then what are the tests that will be done for metabolism? Suppose to find out whether the metabolic activities are normal. So what are all the tests that you will do will be for carbohydrate metabolism, mainly galactose metabolism is taking place here, galactose. So you will do galactose intolerance test. As how to do it, we will see in the next slide. So galactose intolerance test we will do for metabolism, carbohydrate metabolism. And for lipid metabolism, they will do what is the cholesterol level, what is the TGL level. So they will do these tests to find out the lipid metabolic activities. And they will find out the amount of ammonia. The amount of ammonia in the body that is going to be excreted as urea, and this will be from the protein metabolism. So all these metabolic activities, they take place in the liver. So I told you galactose metabolism, galactose tolerance test. So this galactose tolerance test is done under two procedures. First procedure will be, they will take 350 milligrams of galactose, and this galactose cannot be taken orally, so they will mix it with 25 to 30% solution. So they will mix it with water and make it a solution, 25 to 30% solution, and they will give it intravenously. So they will give by IV intravenously. Within 3 minutes they will give. Once they have given, so immediately they won't do anything. They will wait for 1 hour. So capillary blood will be taken. Blood need not be taken from IV. They will take capillary blood from the fingertips or toes. So capillary blood will be taken every 10 minutes for 1 hour. So they will be taking capillary blood for 1 hour every 10 minutes. So totally 6 samples they will take, and they will find out the normal half-life of galactose. So half-life of galactose will be 10 to 15 minutes, will be the half-life time of galactose. And another test they will do will be 14C labeled galactose. They will take a 14C labeled galactose, and it may be given, and the estimation of 14C labeled carbon dioxide that is excreted by breath. So carbon dioxide we are exhaling, so it will come in the breath. So from the breath they will take the carbon dioxide, and they will find out the 14C labeled carbon dioxide, and it will show you how the liver is. So it will be easy for you to find out the galactose metabolism and whether the galactose metabolism is normal in your liver tissue. So you can find out whether the liver tissue is normal or not. Then what are the substances that are synthesized by the liver? I told you a lot of synthesis is taking place by the liver. So what are all the substances synthesized by the liver will be non-specific and specific. Non-specific items that are being produced by the liver will be glucose, cholesterol and TGL. Directly they won't be producing glucose, cholesterol, TGL, but indirectly as a sub-product they will produce glucose, cholesterol and TGL. They are non-specific. But certain things will be specific. Directly produced by the liver will be proteins, bile acids and coagulation factors will be directly produced by the liver, and this will be indirectly produced by the liver. Non-specific and specific items that are being synthesized by the liver. And specific items to access kinetic function will be, so these are all the things we will do. So serum bile acids concentration, plasma protein, especially albumin, all these we will do in the laboratory. So albumin and prothrombin time, PT, prothrombin time, and partial thromboplastin time, PTT, partial thromboplastin time. So all these, these two for coagulation factors, and this is for proteins. So we will do these investigations in the lab to find out whether the liver is functioning normal or not. Then I told her it is very, very essential to excrete, to dissociate this, throw away the ammonia from the body. If ammonia stays back in the body, it is very, very toxic. So this ammonia has to be converted into urea, and it will be excreted from the body through urine. So it is useful, sudden, massive destruction of the liver. So you have to find out the ammonia level. And in hepatic encephalopathy, serum ammonia level will increase. So if the ammonia level increases, we will get hepatic encephalopathy. And it is helpful to determine the stage of hepatic coma. Finally, the patient will go in for coma, hepatic coma, if the ammonia level increases. So for that, you should know what is the normal ammonia level. Normal ammonia level that is there in the body will be 11 to 32 millimole per liter. 11 to 32 millimole per liter. All the normal levels you should be mugging up. You should know everything, because they may ask this in the MCQs. They will put different values and ask you to find out the ammonia level. So 11 to 32 millimole per liter. It is increased in hepatic encephalopathy. Then how to assess albumin? Albumin is synthesized by the liver. Albumin is a protein. Albumin and globulin are the major components of the protein. So here albumin is synthesized by liver. What is the normal level? Again, normal level is important, 3.5 to 5.5 grams per deciliter. Grams, not milligrams. Grams per deciliter, 3.5 to 5.5 grams per deciliter. And it will stay back in the blood of life 20 days. And this albumin level will be decreased only in chronic condition, not in acute condition. Suppose the disease is very acute, the albumin level will be normal. But in chronic conditions like malnutrition or nephrotic syndrome or kwashiorkor, in all these cases are chronic conditions where the albumin level will be very, very low. But in acute conditions, albumin level will be normal. And AG ratio, AG is albumin globulin ratio, is altered in chronic liver damage. Chronic liver damage, because albumin will be very low, and to compensate that, globulin will be high. So the AG ratio will be altered. So this is how you do the albumin estimation. Then prothrombin time. Prothrombin time is very, very important for finding out the prothrombin level in the body. So it is a coagulation factor. Liver synthesizes most of the coagulation factors. If prothrombin is not synthesized by liver, then PT will be increased. Prothrombin time will be increased. Once the prothrombin time increases, so bleeding won't stop. So you just take the teeth from the patient, automatically the patient will die of bleeding. So you have to be very, very careful. So you have to do prothrombin time for any case before plucking the teeth. So it can be due to vitamin K deficiency also. So what is the normal prothrombin time? 12 to 14 seconds. 12 to 14 seconds. If the prothrombin level is normal, the bleeding will get arrested in 12 to 14 seconds. So prothrombin time will be 12 to 14. So this may also be asked as MCQ question. And what is partial thromboplastin time? PTT. PTT. Partial thromboplastin time will be prolonged because prothrombin is less. Then plasma fibrinogen is also being produced by the liver. Plasma fibrinogen level goes down in liver impairment. Whenever there is a liver impairment, fibrinogen level will also go down. So what is the normal fibrinogen level? 200 to 400 millimole per deciliter. So this is also another MCQ question where they will put different values here and ask you to find out. So normal fibrinogen level will be 200 to 400 millimole per deciliter. And these things, are very, very important before taking up tooth extraction in patients. And these tests are very, very important. So these facts are very, very important to you. So what is the total hemoglobin level in the body? So what is the total hemoglobin level in the body, complete body? Suppose you are going to be 50 kg or 60 kg. What is the total hemoglobin alone? Will be 750 grams. Where is this hemoglobin present in the body? It is present in the blood. It is in the hemoglobin of the RBC. So total hemoglobin in the body will be 750 grams. So this life, what is the life of the RBC will be 120 days. After 120 days, all the RBCs, they get lysed. They get lysed, and there will be a turnover of this hemoglobin. So what is the daily turnover of the hemoglobin will be 6 grams. So 6 grams of the RBCs containing 6 grams will be dying daily, and the new RBC will be produced. So the daily turnover of hemoglobin will be 6 grams. And this 6 grams of hemoglobin will be converted into biliverdin, then bilirubin, so you have to make it water soluble. For that, you have to take it to the liver, and the conjugation takes place in the liver. And conjugation, after conjugation, this water soluble bilirubin will be converted into stercobilinogen and urobilinogen. Urobilinogen will be excreted in the urine, and stercobilinogen will be excreted in the stool. Everything we have already told you. And this conjugation takes place with the glucuronic acid in the liver. So these facts, are very, very important to you. And this is the heme structure. I have already shown you. This is the heme structure containing 4 pyrrole rings. This is one pyrrole ring. This is another pyrrole ring. This is another pyrrole ring. This is another pyrrole ring. So 4 pyrrole rings are there in the heme structure. They are connected by methylene bridges. This is one methylene bridge. This is one methylene bridge. This is one methylene bridge. In the center, you are carrying one ion. This ion is being carried by the 4 pyrrole rings. Every ion molecule will be carrying one oxygen. So this is the oxygen carrying ion. So that is how this hemoglobin will be attached to the globin. So 4 globins, will be there. So 4 hemoglobin, 4 ion molecules will be there. So every heme will be carrying 4 oxygens, right? So this is the fate of bilirubin. I told you what happens to the bilirubin in the reticuloendothelial system. Hemoglobin will be converted into heme and globin, And this globin is a protein, so it won't get excreted, so it will go to the protein pool. This heme will be first converted into biliverdin. This biliverdin will be converted into bilirubin, and this biliverdin and bilirubin are unconjugated. Unconjugated means they are fat soluble. They are unconjugated. They have to be converted into soluble bilirubin. For that, they are taken to the liver. Who is taking this bilirubin or biliverdin to the liver? This albumin will be carrying this bilirubin to the liver. So in the liver, it will combine with the glucuronic acid to be converted into conjugated bilirubin. And this conjugated bilirubin is a water-soluble bilirubin. So easily they will be converted into mesobilirubinogen and stercobilirubinogen. They will be converted into stercobilin and urobilin excreted in the urine and the stool. Right? This is about the fate of bilirubin. And this is about the conjugation. I told you the conjugation takes place with the glucuronic acid. UDP glucuronic acid, bilirubin combines with the UDP glucuronic acid in the presence of glucuronyl transferase converted into bilirubin monoglucuronide. Two steps are there. First, it is converted into bilirubin monoglucuronide, and this monoglucuronide again it will combine with the glucuronic acid to give you diglucuronide, bilirubin diglucuronide. So this is the conjugated bilirubin. So two steps are there. Two steps are important. In the next PowerPoint, I will show you what is the importance here. Just to assess the excretory function. So I told you bilirubin is produced by from the heme, and the total bilirubin level will be 0.2 to 1 milligrams per deciliter. 0.2 to 1 milligram. So it is less than 1. Easily you can say it is less than 1. 0.2 to 1 milligram per deciliter. And increases in all kinds of disorders or injury to the or infection to the or carcinoma of the liver. In all these liver disorders, it will be elevated. And depending on the disorder, it will increase the enzymes. So you have got obstructive jaundice. Obstructive jaundice, wherever there is obstruction in the bile flow, this things will be elevated. Direct bilirubin will be elevated. ALP is alkaline phosphatase will be elevated. Gamma glutaryl transferase GGT will be elevated. This is otherwise called a polyesmal enzyme. So all these will be elevated in obstructive jaundice. But this ALT and ALP, they will be elevated in the hepatic jaundice. Alkaline phosphatase and alanine aminotransferase. So both will be elevated in the liver disorders like hepatic conditions, hepatic disorders. But in obstructive jaundice, ALP and GGT will be elevated. So we will see one by one later. So normal levels, I have already told you, plasma bilirubin will be 0.2 to 0.8 or less than 1, you can say. So you should be knowing to find out whether the patient is having jaundice, where you will just see. So you will just see in the sclera, you will see in the conjunctiva, you will see the skin, you will see the mucous membrane in the mouth. So all these areas will be yellowish discoloration will be there. In the sclera, conjunctiva, skin and mucous membrane. But the skin of the adults, it won't be seen, but the skin in children. In children, skin of the thing will be yellowish in color. And all these areas you will have to look for the increased bilirubin level. Then suppose the bilirubin level increases. What is that condition called? It is called hyperbilirubinemia. Hyperbilirubinemia, increased bilirubin level. So this increased bilirubin level is by the increased bilirubin level, we can divide into conjugated hyperbilirubinemia and unconjugated hyperbilirubinemia. Two types of classification you can make. One conjugated hyperbilirubinemia and unconjugated hyperbilirubinemia, whether it is a direct or indirect. So conjugated will be direct and unconjugated will be indirect, right? So another classification is there, the hyperbilirubinemia by congenital disorders or acquired disorders. There are some conditions where the jaundice will be there in the child from childbirth. From the first day of labor, the child will be having jaundice. So it is called congenital. Acquired is, it is acquired after 1 or 2 days. That is acquired. So two types of hyperbilirubinemia. So congenital hyperbilirubinemia, I told you, what are they? Gilbert's disease, Crigler-Najjar syndrome, Dubin-Johnson syndrome, and Rotar syndrome. All these will be, four will be congenital hyperbilirubinemia. It will be there in the child from the childbirth. The child is born with jaundice. So in which conditions means Gilbert's disease, Crigler-Najjar syndrome, and Dubin-Johnson syndrome, and Rotar syndrome. And what is Gilbert's disease? Yes, it is an inherited disorder, autosomal dominant. Autosomal dominant, inherited disorder. And the bilirubin level goes up to 3 milligrams per deciliter. And except this jaundice, there won't be any other symptom. The child will be yellowish in color, that's all. And when you give high carbohydrate diet, and the bilirubin level will go down. Once you start giving high carbohydrate level to the child, the bilirubin level will go down. And high incidence in male than female. So this is about the Gilbert's disease. Then Crigler-Najjar syndrome has got two types, type 1 and type 2. So in the conjugation, I told you, conjugation first step and the second step. If the first step is deficient, so type 1 is congenital and non-hemolytic jaundice, and deficiency of UDP glucuronil transferase, and here the child will die if it is there 2 years, die before 2 years. And the child will be having kernicterus. Kernicterus means the level will be very, very high. The level, the bilirubin level will go up to 20 or 30, and the child will develop brain affection, and the child will develop kernicterus and die. And this is type 1 Crigler-Najjar syndrome. And type 2 Crigler-Najjar syndrome, here the second step in the conjugation is affected. So here the bilirubin level will be low and there won't be any kernicterus at all. So that is the two types of Crigler-Najjar syndrome. Then is Dubin-Johnson syndrome, and this is autosomal recessive, and bilirubin gets deposited in the liver. In this case, the bilirubin will get deposited in the liver, and the normal liver will be brown in color. But here in this case, because of the bile deposition in the liver, it will be black color. The liver will become black, black liver jaundice. So that is called black liver jaundice because of the high deposition of the bilirubin in the liver. And here, excretion of the bilirubin will be, you can do this BSP test to find out whether the child is having this Dubin-Johnson syndrome. So it is an autosomal recessive condition. The acquired hyperbilirubinemia is acquired after 2 days. So after 2 days, the child will be having jaundice. So during birth, when the child is born, everybody will come and see the child. Child will be normal, no yellowish discoloration. But after 2 days, once the mother has started feeding the child will be getting hyperbilirubinemia or jaundice. So that is called physiological jaundice. physiological jaundice of the newborn. So this will come after the second day of labor. Second day of labor, physiological jaundice. And starting from the second day, low-grade jaundice will be there. The jaundice will be light jaundice. Low-grade jaundice will be there. But this will disappear automatically within 2 weeks. And what is the treatment they have to do is, you have to put the child under sunlight. See, treated with not physiotherapy, this is phototherapy. You can correct this, it is phototherapy, not physiotherapy. So treated with phototherapy means you have to expose the child under sunlight. So then you have to give barbiturates to induce conjugation. So this will be the treatment for this physiological jaundice. What is the cause for this physiological jaundice? What is the cause? It is always influenced by breastfeeding. Suppose when the child is born, immediately the child will be fed by the mother's milk. So this breastfed children, in this breastfed children, the children get a physiological jaundice. How? Why? The estrogen level in the milk will be high. See, during labor, this estrogen is a hormone that is very, very important for delivery. So this estrogen will be high in the breast milk also. So when the estrogen is given along with the milk, so this estrogen has got a hemolytic effect. So it will break down the RBCs. This estrogen will break down the RBCs and it will cause hemolytic jaundice. That will cause hemolytic jaundice. So will you stop breastfeeding because of this reason? No. You should not stop breastfeeding. You have to give breastfeeding. It is the right of the child. But a child may develop a physiological jaundice which will get corrected within a week. So child will become alright within a week. So you have to continue breastfeeding. And also this unsaturated fatty acids and lipase in the breast milk also will cause this physiological jaundice. Unsaturated fatty acid and lipase that is present in the breast milk also will cause physiological jaundice. So this is about the physiological jaundice, acquired hyperbilirubinemia. What are the hemolytic diseases? What are the hemolytic diseases? Hemolytic means breakdown of the RBCs. So what is the cause for this breakdown that causes the jaundice? Hemolytic diseases. One is ABO incompatibility, RH incompatibility, faulty blood transfusion. Other causes like hemolysis, congenital spherocytosis, B6PD deficiency, autoimmune hemolytic anemias, and toxins like carbon tetrachloride. What is ABO incompatibility? If the mother is A group or B group and the father is A O group, and this ABO incompatibility, this blood grouping won't sometimes won't match. So this ABO incompatibility between the father and the mother may affect the child. So it will affect the child. So that is called the hemolytic disease, which will cause jaundice. Mother happens to be RH negative and the child is RH negative, nothing will happen. But if mother is negative and the child happens to be positive, the first child will escape, but the second child. Hello students, there is some disturbance from your side? Yes. So what are all the tests based for the proteins? The total protein, albumin and globulin. You will be doing levels per deciliter, and in this albumin will be 3.5 to 5.5, and here globulin will be the remaining. So globulin will be reverse. It will be there in nephrotic will be less and globulin will be more. And then you will have to do prothrombin time to find out the level of prothrombin in the liver, because prothrombin is a coagulation factor, so that is very, very important. And what are all the enzymes that are being produced by the liver will be transaminases. One is ALT, alanine aminotransferase, and aspartate aminotransferase. Alanine aminotransferase will be more in liver disorders, and aspartate aminotransferase also will be elevated. So what is the normal level? Alanine aminotransferase will be 3 to 15 international units, and aspartate aminotransferase will be 2 to 20 international units per liter. And what are all the enzymes of cholestasis is obstructive. Cholestasis means obstruction. So what are the enzymes in obstructive jaundice will be alkaline phosphatase, ALP, 25 to 90 international units per liter, and 5 nucleotidase will be 2 to 10 international units, and gamma glutathione transpeptidase will be 10 to 30 international units. All the three will be elevated in obstructive jaundice. Then you have to do caffeine clearance test. Caffeine clearance test, and this is also another important test for the liver. And for that, what you have to do will be assessment of caffeine. Caffeine is just in the coffee. So assessment of caffeine clearance can provide a useful measure of hepatic microsomal activity. So for that, what you have to do, this caffeine will be rapidly and nearly completely absorbed by the GI tract following ingestion. So you have to take this caffeine with fluid, and we have to see how much it is being absorbed. Absorbed caffeine then undergoes N-demethylation, and how it is done will be, you have to take oral administration of caffeine. Oral administration of caffeine as coffee, you can take 3.5 milligrams per kilogram body weight you have to take to a maximum dose of 200 milligrams. So this is dissolved in either water or fruit juice or milk. So you have to mix this caffeine and you have to take. And you have to take the blood or salivary samples you can collect, and before and after caffeine ingestion, and analyze. And the caffeine clearance rate will be 2 ml per minute per kg in adults. 2 ml per minute per kg in adults, and 10 ml per minute per kg in healthy children. So you have to do it like this, and you have to find out the caffeine clearance test. And the half-life of caffeine is this, and it is approximately 5.5 hours in adults and 3 hours in children. So this caffeine clearance test is also done in liver function test. And to know the storage, part of the liver, what are stored? Glycogen is stored, iron is stored, and also vitamins also they are stored in the body. So glycogen storage and iron storage and other factors alternate, and it is not specific. So both will be stored in the liver, glycogen and iron. And what are all the liver injury markers? All these tests you have already done. And the total protein you have to do, that is 6 to 8 grams per deciliter, and total albumin will be 3.5 to 5 grams per deciliter, and the total bilirubin will be up to 1 milligrams per deciliter, and in that 1 milligram How much of direct and indirect you should know? Direct will be 0.25 and indirect will be 0.75 milligrams per deciliter, and the alanine aminotransferase ALT normal level up to 50. Up to 50 you can have milligrams per deciliter, and the aspartate aminotransferase is AST up to 45 is normal, up to 45, and alkaline phosphatase will be 60 to 170 milligrams per deciliter, and the gamma glutarate transferase GGT will be 15 to 85 milligrams per deciliter. So all these investigations are done to find out the normal functioning of the liver. Thank you, my friend. Today we have seen the very important chapter, liver function test. Normal functions of the liver have been shown, and what is the importance of the liver function test I have shown you. And before doing any extraction, you will have to do all these investigations before taking up any surgery or any procedures for the students, for the patients in dental. So all of you just read this and make yourself ready. And all of you have your mask in the house. Whenever you are going out, always maintain the 1 arm distance between people, and always keep yourself, because the second, from second, we are likely to get the third wave. So don't allow the third wave to come, because that will affect the children most. And all of you just be cautious and careful. So with this little bit of warning, so I thank you very much.